İnniki çıkışımız bilen devam edelim. Bizim çıkışımız, inniki çıkışımız Doktor Serdar Charyyev çıkış ediyor. Serdar Charyyev 2013 yılda Türkiye'nin Orta Gündoğu Teknik Üniversitesi'ni bitiren, Türkiye'de okuyanlar ODTÜ deyip biliyorlar. Orta Doğu Teknik Üniversitesi, or Middle Eastern Technical University. 2018 yılda Georgia Tech Üniversitesi'nden institutundan magistrasyonu alan Medical Physics, 2019 yılda Shower Institute'dan Medical Physics bölümünün doktoranturasını gören, 2019 yılda Şol Institute'da Teaching Assistant olup işen, 2019 yıla çenli, 2022 yılda Emory Üniversitesi'nde Physics Resident bolan, 2022'den beri olsa Stanford Üniversitesi'nde Clinical Assistant Professor bolup işleyen. Onun bu çıkışının adı Artificial Intelligence, Emeli Akıl in Particle Therapy. Serdar Charyyev, hoş geldiniz. Doktor Charyyev. TASA sizinki.
Tanıştığınız için çok sağ olun. Benim öz yerimde TASA sağ olsun diyen şu yere beni çıkış etmeye çağıranlar için. Yöne men kayırsız ağan çıkışından katı gördüm Türkmençe olan için. Benim çıkışım biraz teknik olan için ve auditoriyada da Türkmen diline düşmeyen tanışlarım var olan için İngiliz dilinde prezentasyam etmeye makul bildim. Yöne prezentasyonun sonunda eğer Türkmen dilinde sorular var olsa okuyumun yeteninden ben Türkmen dilinde de cevap vermeye sinusça. Ve hazırda başlayıp İngilizce öğrenmiş. Okay, so as you settle, the topic of today's talk is going to be artificial intelligence in particle therapy. I'm pretty sure some of you, one way or another, have interacted with the artificial intelligence. ChatGPT is like part of most of our lives now, especially the professionals. So I thought maybe this topic is meaningful in the sense that AI is becoming a bigger part of our lives. Certainly, it's becoming a bigger part of my job. So probably I will make an introduction about myself first. So I'm Serdar Charyyev. I'm currently a clinical assistant professor at Stanford University in School of Medicine and Department of Radiation Oncology. My primary appointment is clinical, about 85–90%. I have clinical duties. On top of that, I have some teaching duties. These are the courses, medical physics and dosimetry and physics of radiation therapy that I taught this year. Every year we have different courses, obviously. Then bigger part of my job duties is again research as well. So when I have some time, I research about AI techniques and the way we can apply them in radiation therapy and specifically particle therapy. Before this, I was at Emory University doing my residency in Department of Radiation Oncology. And before that, I was at Georgia Tech doing my PhD. So this is a kind of overview of what I'm going to talk about today. I'll make a quick introduction about what medical physics is, and then dive into the radiation therapy. I really was hoping that Dr. Charyyev was here before me to make an introduction about the ways to treat cancer, but unfortunately he is absent, so I'll have to do that for him a little bit. Then at the core of this talk is AI, how to apply this in radiation oncology. I divided this into two because the cancer treatment in radiation oncology happens in the planning stage and in the delivery stage. So AI can help us in both. So I'll try to give examples to that, and I'll conclude with some remarks. So what is a medical physicist? So as the name implies, medical physicists are healthcare professionals that specialize training in medical applications of physics. They are concerned, as you can see, with the 3 areas of activity, mainly clinical service and consultation, and research and development, and teaching. So the time may be distributed equally or not based on the nature of your appointment. So it could be you are in a research institution or more in a clinical setting. So the weight of the activities that you're doing under this umbrella will be different. So as far as the clinical service goes, it depends really on your track. So if you are in radiotherapy, we have some radiotherapy machines in the clinic. So we'll be involved with the clinical commissioning and quality assurance of those machines. Delivering correct radiation dose to the tumor is the actually utmost importance to us. So we'll try to strive for that. So we'll do routine quality assurance to keep those machines in compliance with the initial installing conditions. On top of that, we review plans developed by dosimetrists to verify that those treatments are safe and efficient and can be delivered with the machine. So we could be called upon to the clinic to contribute clinical and scientific advice and the physics resources. And there are obviously numerous and diverse problems that arise in a cancer clinic. So you may be called for consultation and advice. So this is if you're in radiotherapy. So if you are in diagnostic or interventional radiology, then you'll be dealing with the machines that do the diagnosis. So mainly CT, ultrasound, mammography, fluoroscopy, what have you, MRI. If you're in nuclear medicine, then you might be involved with the quality assurance of devices like PET CT, SPECT CT, gamma cameras, and so on. You might be preparing radiopharmaceutical to be injected to the patients. You might be in the radiation protection aspect of the profession. And in that case, the expectation is that you understand how radiation can affect the human body and the environment and what you can do to protect it, right? So every hospital that has some radiation source or has some radioactive materials, they will have some workers who will kind of assess, monitor the radiation dose, and follow the radiation procedures. So you might be doing that type of work. We are at the same time instructors, so we train others. Often we are in the setting of medical school, so we will have residency programs, we'll have graduate programs, and we'll be teaching in those programs. We teach resident physicians, resident physicists, medical students, technologists, our peers, and so on. We do research, so and probably the primary reason we gather here. And really what a medical physicist can do is multifaceted. So if you, for example, in therapy, you can have an external beam, brachytherapy, particle therapy. These are all slang in my department. You could be working in the imaging to improve the image quality, or just work with other departments to find novel radiation delivery techniques. So I think it's enough for the slide. So let's move on. So what are your options, right? So if you are in this job, where do you work? I mainly took this data from American Association of Physicists in Medicine. As the nature is, you can work as a clinical job or non-clinical job. As you can see, most of the medical physicists are clinical. I'm clinical. When I say clinical, it does not mean I do not teach or I don't do administrative work. It's just most of my time I spend on clinical work. And what I mean by non-clinical, then that could be academic positions, administrative positions, regulatory positions, and so on. In terms of primary discipline, you can work as a physicist in radiation oncology. diagnostic radiology, and others. As you can see, the pie is kind of divided a lot. And the majority of medical physicists work in radiation oncology department. I work in radiation oncology department. In terms of the primary employment, you can work in medical school. Usually they are part of university hospital. Our medical school is a part of Stanford University. Before that, I was at Emory University again in School of Medicine. You can work in the private or community hospital. For example, in California where I live, Kaiser Permanente, for example, employs a lot of medical physicists, right? Or VA hospital, Houston Methodist, examples. And that's about equal distribution, as you can see. You can be a part of a service group. You can work at a smaller cancer center. You can work in industry, government, and others. So this is kind of my brief PR of medical physics. Among you, if there are any physicists, aspiring physicists doing PhD in physics, biophysics, or related engineering fields, please reach out to me. We can talk more, and I can give you more information. This is very niche. Our association has 10,000 members all over the world. People know each other, so a lot of people don't hear about this. So let's go into radiation therapy. So the treatment options, probably, if Dr. Chowdhury was here, probably he will give some information about these. So I was going to skip the slide, but in his absence, there are kind of options for cancer treatment. And what I'm dealing with is really this part here, radiation therapy. And radiation therapy is kind of divided into internal radiation therapy. We call it brachytherapy, or external radiation therapy. And external radiation therapy, depending on what type of radiation you give to the patient, can be called particle therapy. We treat with the particles, for example, protons, carbons, heavy ions, or with the photons, X-rays, then we'll just call them radiation therapy. So I'll just talk about this. So any patient that goes in the radiation oncology department will kind of go through this workflow. I'll spend some time to explain this because each stop here, we can use AI to help us. So when the patient walks in the hospital, obviously at that point, they will have a consultation with a radiation oncologist. And at that point, their cancer is already known, diagnosis is already there. So they will have some report from pathology, report from radiology. So they will be like, okay, here's my tumor, the location, the type, the stage, and so on. So with the radiation oncologist, they will have a consultation about what are my treatment options in this department. Are we going to use internal therapy? Are we going to use external therapy? How many fractions, how many days I'm going to come here, right? So all of those will be outlined. Then based on that discussion, they will go into simulation. So the simulation, as the name implies, will put the patient in the position that they're going to be treated, and we'll take a CT scanner. And that CT scan will give us kind of 3D idea about the patient itself and the kind of relative environment. And based on that CT scan, we'll start doing what we call contouring. So we'll send that 3D scan to physician, and physician will draw what they are going to treat. We call them targets, and what they are going to avoid. We'll call them organs at risk. So the primary goal is to give the full radiation dose to the target and give no radiation dose to the organs at risk. It's usually easier said than done. So there will be some tug of war between target and the organs at risk. So that part is called contouring. Where are you going to treat, right? The physician will draw. And then the plan comes to us. So we'll do the planning, right? In the early days, obviously, the planning was all handwork. You know, we draw blocks and so on. I'm talking about 80s. I wasn't born at that time when I'm talking about. Now we have very sophisticated software that can do everything automated, can do optimizations. We can do little tweaks, and we can come up with a good treatment plan. We'll consult with the physician. Physician likes it, we approve it. There's a stage between planning and delivery. We call it quality assurance. This picture doesn't have it, but we'll go to the machine that the plan is going to be delivered, and we will pre-deliver it, kind of mock as if the patient was there, and see if the machine can deliver it. And we'll measure the dose and compare it to the computer provided dose and make sure that they are equal. So that's the quality assurance part. Obviously, there's a lot of other chart checks going on, not worth spending time. But then there comes actual delivery. So the patient comes in, we'll put it in the same immobilization that we did in the simulation, then we will deliver the radiation dose. And as I said, that course may be one treatment, it could be 5, 3, 20 some treatments, and so on. And then obviously we have a follow-up. So as I said, this is like the early days. There were 2D treatment, then we evolved into 3D treatment, and so on. Right now, we have fancy machines, linear accelerators, MRI Linacs. We have ion beam therapy and that 3 dots. So we are always striving to shape that tumor really conformal to that tumor. And this conformality obviously reduces the dose to the organs at risk. We still have problems. In the pediatric cases, in the central nervous system, we are still limited by that upper dose tolerance of some organs. We cannot continuously dose escalate and kill the tumor completely. One good case is glioblastoma. Very hard because it's very radio resistant, not a lot of treatment options, but we cannot continuously escalate it. It's in the brain stem will fail, optic nerves will fail, we don't have options. So we are still looking for that, what's new, right? So is AI that can replace that 3 dots, 4 dots? I don't know. But it's just worth talking about AI as applied to radiotherapy and specifically in particle therapy. So going into that, AI in the planning stage, right? So as I said, in the contouring, we give physician this. But picture on the left, you can see it's just a slice of a pelvis of a patient. And then we want them to go into that right slice. We want them to contour me. Where's the bladder? That orange contour. Where is the prostate, right? I should have a laser. Okay, great. So technology. Okay, the prostate, right? Seminal vesicles, rectum, femoral heads. We want physician to contour this. How is physician doing that? Here. So physician goes and takes a pencil, just like in paint, and contour it on each slice. And you can see that this contouring of, let's say, prostate is going to take him a few minutes. Then he has to do the same thing for femoral heads, has to do the same thing for rectum. And by the time he's done with these contours, he will spend 2 hours. This can easily be automated with AI. So on the right side, you can see with one click, AI can do wonders. So in a few seconds, it can just delineate things. The patient anatomy, human anatomy, pretty much same. If you give it enough data, it can contour everything in a matter of seconds. Obviously, we don't use this in the clinic as is. The physician still goes over this and makes some tweaks, but the majority part is done, right? And this is AI. So is AI perfect, right? Here's a recent study by Baruti et al. Comparing the predicted contours to the ground truth contours. And you may ask, what is the ground truth? And the ground truth is the manual contours from physician. For now, they are ground truth for us. In the future, maybe AI is so developed that they do better job than physician. But for now, we trust what radiation oncologists contour. And one of the metrics to evaluate whether the contours are similar to the ground truth is what we call dissimilarity coefficient, which measures the basic spatial overlap. It runs from 0 to 1, with 0 indicating there's no overlap, and with 1 indicating complete overlap. So you can see that AI-generated organs, in this case, this is the duodenum here, and this is the small bowel, and you can see the duodenum is a little bit different here, and you can see the bowel is kind of over-contoured in the prediction, right? So, yeah, they are not same as the physician contoured organs, but they may be clinically acceptable. If the dose metrics are same, physician may say, yeah, it's okay. It doesn't really make difference in the dose distribution. So we can proceed with this. But this case kind of shows you how AI-generated contours should be evaluated by the attending physician. And for that reason, we have a lot of contouring challenges like this one. happened in Singapore, MICAI, during MICAI 2022, right? And you can see that on top of a lot of research institutions, obviously there are some industry people, right? So there has been commercial solutions, and this is obviously like widely used in radiotherapy. So the next step, right? So we have our contours. Then we go from this to that. So what is this color cloud? This color cloud is the dose distribution. So now we bring in the machine parameters and we try to deliver the dose to here and obviously spare this, spare that, and spare this. And as I put this into 100% specifically to show that this and these two contours are targets. So they are trying to be, they are trying to treat those two, right? But before we can even try to calculate those, we need to make sure that the material information in the CT is accurate, right? What does a 3D image, CT image give us? It just gives a 3D matrix of grayscale numbers called Hounsfield units. It does not give us material information. We have to go from Hounsfield units to material ourselves, right? So how do we do that, right? So the way we have been doing this in the realm of particle therapy is we have been converting from Hounsfield units to stopping power ratios. It's again, technical term. I'll abbreviate it as SPR from now on. So this SPR information in each voxel is what we use to get the material information in that voxel. And the standard of care right now is just a linear fit between HU, Hounsfield unit, and SPR. Obviously, it comes with a lot of problems. One is it's a many-to-one mapping. So a lot of HU numbers can correspond to one material, or one HU can correspond to different materials. So it's not really good. There are intrinsic fitting errors in this process. And even though patient anatomy can be more or less the same, obviously a lot of patients have heterogeneous distribution. So it's really a tissue. So it could be different. So what to do, right? The answer could be dual energy CT. Now, the dual energy CT is a premium scanner. So it has another energy. So it's a little bit expensive. With that additional energy in dual energy, we can sample materials, meaning that we can use it for a lot of application, like, for example, bone removal in angiography, or stenosis identification, or kidney stone characterization. So in radiation oncology, particularly with the proton treatment planning, dual energy CT has been shown to get accurate SPR information, so accurate material information. So we thought about it and said, okay, then in the setting where we have single energy CT, can we just use that to train and get dual energy CT from a single energy CT using the deep learning? And then we can use the synthetic dual energy CTs to calculate the SPR, accurate SPR, hopefully. So this comes in handy in the clinics where dual energy CT scanner is not available. So this kind of figure summarizes the findings of this small work on an exemplary case here. This is a head and neck or brain case in the head anatomy. And you can see that the ground truth and the synthetic image are visually, at least, not discernible from here. And you can see that the detailed analysis where this yellow box has been kind of blown up and this profile of this red line is shown here with the HU numbers. And there are HU differences, very small, less than 20 HU. So kind of our quality assurance number. So we are looking for small HU differences. How about the calculated SPR? So we calculated the SPR from the synthetic dual energy CT, and it was close to that from real dual energy CT. And as indicated by the cyan arrows here, there could be a noise and artifacts.
Online audience is asking, can you use mouse as well?
Okay.
Because they can't see.
Oh, okay, probably.
Can't see the laser.
Oh, I see. Okay. So online audience, is there online audience in here that also connected to Zoom can see this screen?
No, we can't see. I'm monitoring here.
I see. Okay. Apologize for that.
From your, we're not sharing the screen. We're sharing from the.
Okay. Okay. Apologize. I'll try to use the mouse here as well. Okay. But anyway, so we did an evaluation on the first few patients. I'll just talk and probably enough. So on the bottom graph here, and this is obviously not a full dosimetric comparison. The full dosimetric comparison is still ongoing. It's only 5 patients. We kind of quickly wanted to get idea if our SPR, calculated SPR from synthetic dual energy CT is good and even good enough, right, for dose calculation. For these patients, we found out the dosimetric difference is within 1%. So we are at least happy for now. How about the AI in delivery, right? So that's the kind of last step. So in this step, when patient comes in, we'll set them up on the linear accelerator, and then we want to kind of have some images, right? So we just don't set up and treat them. We image them first, and we make sure that the image was taken during the simulation corresponds to the image that we take them now. If it doesn't correspond, then we'll do some matching. So we'll move the patient around. And if the matching is really not good, then we'll walk the patient a little bit, put them back, set them up again, and then we treat them, right? Image each time. So those images we call the basic images is portal images. So you can see a portal image on the left side here, and this is an X-ray portal image. Right. So this is the most basic information. On top of this, we'll do 3D images as well, what we call cone beam computer therapy. But the basic, we'll just do portal image, and it's mostly good enough for bony anatomy. So then there is something called proton portal images. So that's on the right, and you can see the quality is really, really blurry. I mean, as compared to the left side has a lot of details. The right side, there's really not good details. And then we need proton portal images in some instances because, first of all, even though we take the images with the X-rays during the particle therapy, we do not treat with the X-rays. We treat with the particles in this discussion with the protons. So it would be nice if we can get the images from protons because it will be the native gantry angles with the particles that we're going to treat with. And in a new developing treatments like FLASH, there are a lot of protons exiting the patient. So it's just, in my opinion, waste of protons. So we could use those to do some imaging. But the image quality is really bad. So we thought, okay, can we use AI to improve it, right? So we did a little study where we obtained proton portal images of head phantom like that by rotating it in a rotary. We also CT'd it, and we obtained a digitally reconstructed radiographs, called DRRs, at the corresponding projection. So if the projection is 90 degrees for proton, we have the DRRs at that angle. And we use those DRRs as the ground truth to train and try to improve the quality of the proton portals.
We want to leave some time for questions.
All right. So this is one of my last few slides.
Okay. All right.
And we applied a deep learning-based approach to integrate the dense blocks into a GAN framework to synthesize synthetic proton portal images from proton portal images. So the input is proton portal image, but the output is synthetic proton portal image. So the proposed method demonstrated a comparable level of precision in reliably generating the synthetic images. And here again, we do that kind of detail analysis to compare these two with qualitative and quantitative metrics. And here kind of a visual metric where our therapists in the real clinic will use, right? So they will overlay images with the color band or checker type of evaluation. These are really good tools in the clinical setting to see how well the patient matches. So in this test, this was also showed a promising result. So conclusion, I think we are in a golden age in our progress of AI, or at least maybe at the foothills. We don't know what it's going to bring. And particle therapy is perfectly suited to benefit from AI for a lot of purposes. And I try to give some of the examples where we can use it for treatment planning and delivery, but obviously we can use it for speeding up the dose calculation. Usually those things take time. And our group at Stanford, we are working on this. We can work on adaptive type of treatments where if the patient changes during the treatment, we can quickly come up with a new image set and new contours and new plan using AI. So this is also big research. It sounds like they're all promising here. Probably, if there are some AI enthusiasts in this room, probably smiling and laughing inside them, understand, because at one point we should understand that the AI is not a silver bullet, right? It's not a solution to everything. It has its own challenges. The AI models are becoming more and more complex, and it becomes really challenging to analyze what was input and what was output. Was it manipulated in some way? Is AI hallucinating? All of these are challenges and pitfalls. And we really need to carefully interpret and check the results. With this, I'd like to thank my old mentors, new mentors, collaborators, and I try to answer the questions if you have any.
Sorry, we need to use the platform together. We use it.
Sounds good to me.
Let me see if we have any questions. Dr. Charyyev, please reach out to me working on the okay. It would be an all right.
So this must be from Instagram.
Yes.
So I'll get the name of that person.
Yes, LinkedIn havarlaşayıq.
Havarlaşayıq, LinkedIn havarlaşayıq ya da Instagram havarlaşayıq.
Okay. Berden sonra var olsa sonra bilirsiniz. Şu an YouTube'u görüyençek. Okay, give me a second. Ne olur? Mikrofon. Okay, go ahead.
Okay. So you were talking about pitfalls of AI research and such. You talked about how hard it is to understand what the AI thinks. So I assume you had like a third person in the room, like a developer of AI, to work with the AI, to talk to it, right?
So when I say AI models used in our type of research, these models usually, were developed by not like a physicist like us, right? They are developed by companies usually, or some computer scientists, right? So we will take their models, already existing models, and we will tweak their inputs so that our input is what we want to give it and what we want to get out. And in that sense, yes, we'll modify it a little bit, but we are not developing the network from the get-go, from the beginning, right? So yes, if your question is, how do you know? We really don't know, right? But do we have a ground truth? Yes, we have a ground truth. Everything that we get out, we compare to the ground truth, and we will provide it the data that it has never seen before to kind of test it. So that's how we know if this is, just giving us some trash information or not. But you give it a trash, it will give you a trash.
I was asking about I thought if you work with the developer itself of the program, if you have any problems with it.
Yes. So what we have right now is like an interpretable AI, right? So we are developing methods to check if the AI is doing some mistakes too. So this is also ongoing research.
Okay. One last question. As a biomedical physicist, like how much of it is physics and how much is biology? How do you study for it?
That's a very good question. So in our job, I cannot quantify the percentage per se, but if you want to get into this job, you will have to take heavy anatomy, biology classes, obviously, because like you will be looking at the images. At least you need to understand basic anatomy of what you're looking at, right? So are you looking at the duodenum, liver, what's all? And the other thing is, if you want to go into a deep biology research, then you need to know more, because not only you have to publish biological paper, but you also have to convince the reviewers who might be physician, biology expert, radiobiologist, people like that. Yes.
But
Thank you.
I'll catch you.
Catch him. Do we have any other question? That's why I want to give our audience. You tell the question, we can repeat here. I think it would be the best.
My question is in traditional method of treatment on a particle, treatment method or the radiotherapy. Like, does it change the efficacy of the treatment? Does it change based on the patient, assuming the patients two different patients have the same set of diagnostics?
That's a difficult question. The question is the treatment patient specific, right? Treatment is always patient specific. Some patients will come with the same diagnosis. Obviously, the anatomy, what I call the geometry for us as a physicist is not the same. And biology is definitely not the same. So just because the geometry is not the same, they will have slight difference in distribution of the dose and how that dose relates to the organs at risk. And that's one of the things like the outcome prediction. So what will happen to the patients? You need a follow-up. The same patient with the same diagnosis being treated with the same modality could have different outcomes. If you ask the benefit of the particle therapy, yes, there's a benefit. Obviously, otherwise we don't spend a lot of money. The particle therapy is the most expensive modality and arsenal in our arsenal. A 4-room particle therapy treatment can cost, for example, the cost of a wing of a hospital. So, like Bay Area, where I live, 7.5 million people, we still don't have proton therapy. It's a big investment.
Thank you. Let me check the others. Okay. Көп сауал доктор Charyyev берен гурулңаңыз үчүн.
But that's all.